What's up, everybody? Dr. Rossi. I'm a board-certified adult psychiatrist who's been making mental health content related to different psychiatric diagnoses as well as treatment. So if you haven't done so already or you're new to the channel, please like and subscribe. It helps me to continue making this content for you. So today we're going to be talking about an interesting topic. It's one that comes up all the time, and it's going to be bipolar disorder. But specifically, how do we separate bipolar disorder from unipolar depression? So if somebody presents with a depressive illness and it appears like depression, how do we know that it's not bipolar disorder? Now, bipolar disorder might be possibly the most misunderstood and misdiagnosed psychiatric disorder of all time. How many times have you guys ever had like a friend or family member come to you and say something like, "Oh, he's bipolar," or "I feel bipolar today"? And what they're usually describing with this statement is something like a rapid mood change. They're usually saying that their mood is fluctuating sometimes by the minute, sometimes by the hour, sometimes day to day, and they kind of equate this to being bipolar. And unfortunately, this is not necessarily true, right? It would be great if that were true, and then most people would have bipolar disorder. Just about everybody can think of an example in their life where something like this has happened. So this is not the clinical presentation of someone with bipolar disorder. Often this is related more to the person's personality, temperament, and frustration tolerance. So as I've said, bipolar disorder can possibly be one of the most difficult disorders to diagnose in all of psychiatry. And that's because often people present in a depressive state. So when somebody presents to the hospital or somebody presents to the outpatient psychiatrist, they present in a depressive episode. And it can be very easy to miss mania or hypomania, which would completely change your treatment and diagnosis. Episodes of depression are common in both bipolar 1 and bipolar 2 disorder. In fact, in order to be diagnosed with bipolar 2 disorder, you have to have the presence of at least one major depressive episode. What separates them actually, though, is the presence of one or more manic or hypomanic episodes. So what gives somebody the diagnosis of bipolar disorder is the presence of at least one manic episode in their history. Once somebody's had a manic episode or a hypomanic episode, the diagnosis will change to either bipolar 1 disorder or bipolar 2 disorder, depending on the circumstances. This can sometimes take a while for doctors to diagnose because you have to catch the person in one of these episodes. So it just so happens they have to have an appointment with you or present to the hospital because they're having a manic or hypomanic episode. And often hypomania is missed because the person feels really good and it doesn't really impair their function. So they're not getting into trouble as a result of the hypomanic episode. Now, it's common for these people to be treated with antidepressants nude. And what I mean by that is they're being treated with antidepressants without a mood stabilizer because the doctor doesn't know about or hasn't asked the screening questions about mania. So we'll get into that in a second. I'll explain more in a minute. But what ends up happening is this can also precipitate mania or rapid cycling, or in general what we call mood destabilization. So let's go over the key factors that I look for in really any psychiatric diagnosis, but specifically I'm going to be talking about the bipolar spectrum of illness. What are some key things to look out for and common signs that you might identify? So I break all psychiatric diagnoses down into a couple of different pieces. One is course of illness. So how does the illness progress over time? Number 2 is family history. So when we're talking about family history, what we're really talking about there is genetics. Number 3 is the DSM-5 criteria or symptoms, the specific symptoms that somebody is presenting with. Number 4 is the treatment effect. So what is the person's response to the treatment that's being offered? And number 5, what is their response to antidepressants? So let's go through this one by one, and I'm going to say the first 2 are the ones that I consider very, very important in making your diagnosis or when you're thinking about signs and symptoms of bipolar spectrum of illness. So number 1, course of illness. So the course of illness, like I said, this includes things like age of onset. So when did the person first develop the symptoms, the number of episodes across the person's lifetime, and the eventual outcome of the disorder. So what is the eventual end point? Is it episodic in nature? Is it something that's chronically progressive? what is the eventual outcome? In bipolar disorder, what's really important is the age of onset. So in general, with bipolar disorder, the symptoms, either depression and/or mania, are going to occur much earlier than it would in unipolar depression. So a lot of times the average age of onset is somewhere around 20 years old. The person will have their first manic or depressive episode. So if you see an early age of onset, you want to start thinking about bipolar disorder, and you want to screen those patients who present with their first depressive disorder, or depressive episode rather, at that time for bipolar. Another thing you can take away from the course of illness is that the episodes tend to alternate. And what I mean by that is, for example, if the first episode is depression, then the next episode is mania, and then the next episode would be depression. And you kind of see this in the course of illness with bipolar disorder, this alternating between depressive and manic states. And this will kind of occur down the line, and you'll be able to predict what the next episode will be. So course of illness is very important. The second thing I said I consider to be very important is family history. So family history, what we're really talking about there is genetics. So what is the person's genetics? Bipolar illness is highly genetic. It ranks up there with schizophrenia in terms of its genetic component or genetic contribution. If a first degree relative, that being a mother or father, has bipolar disorder and the person presents for the first time with a depressive episode and they're younger in age, you definitely want to screen that person for bipolar disorder, because it's more likely that somebody with one, or in some cases 2 first degree relatives with bipolar disorder will develop bipolar disorder, because it is highly genetic. Number 3 is the symptoms based on the DSM-5 criteria. Now I rank this a little bit lower, although it's still very important. And there's certain key factors that we know help us separate things. So if I'm trying to separate bipolar disorder from borderline personality disorder, there's a couple of key components, things like elevated mood and increased goal-directed activity, that really help me to separate that from some of the other overlapping symptoms, such as anger and impulsivity, which can be found both in bipolar disorder and borderline personality disorder. The fourth piece is the treatment effect. Now I rank this a little bit lower because it's non-specific, meaning that if I treat somebody's bipolar disorder with an antidepressant during a depressive episode, it might actually help them at that time, and I might be fooled into thinking this is just a unipolar depression. This functions in some ways as a substitute for biomarkers. And in the field of psychiatry, we really don't have a lot of good biomarkers. Some are currently being developed, but we haven't been able to really come up with great biomarkers that we can go to. And this would be things like imaging results, EEG changes, or blood tests or laboratory tests to help make a diagnosis. So what substitutes for that is the treatment effect. And that is, how does the person respond to the medication? So there's a couple of key things I will look for here. If a person is placed on a mood stabilizing medication, say lithium for example, and it improves their mood, then we might be on the right track. The second piece to that, if the person's put on an antidepressant medication and it happens to worsen their mood, this is a good indication that we might be dealing with bipolar spectrum of illness. And that brings me to my fifth and final point, which is that antidepressants alone, or what we call antidepressants nude, right, in the absence of a mood stabilizer, if that precipitates an episode of mania or hypomania, I would be highly suspicious for bipolar disorder. This should raise a lot of red flags. And in general, if you choose to prescribe an antidepressant to somebody with bipolar disorder, it should always be in the context of a mood stabilizing medication that's already been titrated to an effective dose, and never do it in the absence of a mood stabilizing medication alone. We'll talk more about that in a future video. So to wrap this video up, what I will say, in my mind, genetics, course of illness, key criteria from the DSM-5 Diagnostic and Statistical Manual, and also treatment response are things that can really help you to separate bipolar disorder from other illnesses, and it can really help you to separate bipolar from unipolar or from things like borderline personality disorder. So if you liked the video, I'm going to ask you guys to please like and subscribe to the channel. It really helps me to continue to make these videos and to continue to work on these important topics.